appears in the sclera. Why? Because sclera is having highly elastic tissue and bilirubin is having affinity for it, right? The second is underneath the tongue. And when this jaundice becomes moderate to severe, then it appears in the skin also. So skin becomes yellow. Now differentials of jaundice. બધું પીવું એટલું jaundice ના હોય એવું હોય. So first is carotenoderma. So what is carotenoderma? The term itself suggests in it only skin discoloration is there, yellow skin discoloration. It spares sclera and it appears because of few drugs like quinacrine and sinotinib consumption, then few endocrinopathies like hypothyroidism, diabetes, and when person consumes lots of amount of keratin rich diet like in carrots, peaches, etc. The second differential is muddy sclera. So what is muddy sclera? It appears only in exposed part of sclera, okay, and it is because of aging. It is because of degeneration of tissue. So that is why આપણે જ્યારે jaundice examine કરીએ ત્યારે આપણે unexposed part of sclera જોઈએ. Okay, we will go in detail later. And along with the skin and scleral discoloration, one can person is having darkening of urine. There is a yellow discoloration of urine also, especially in hepatic and post-hepatic jaundice. So let's get a brief idea about bilirubin metabolism. Extravascular hemolysis occurs. So unconjugated bilirubin is present in the blood. It is bound with the albumin. Then the hepatocyte get this unconjugated bilirubin, and then glucuronidation process happens in the hepatocyte, and unconjugated bilirubin is converted into conjugated bilirubin. So now it is become water soluble or fat soluble. What is it? Yes, it is excreted through the bile, reaches in the intestine, and then it is converted into urobilinogen and stercobilin. So that is why we see the yellow discoloration of urine and feces. Now how to grade the jaundice? So for that you know normal bilirubin level, that is 0.1 to 1.2 milligram per deciliter. Mild jaundice, when bilirubin level is 2 to 5 milligram per deciliter. Moderate, when bilirubin level is 5 to 15 milligram per deciliter, and severe when the bilirubin level is more than 15 milligram per deciliter. Now this is a Kramer staging of jaundice. Usually we apply this staging for the neonatal jaundice. It is we can estimate the amount of jaundice depending on the body parts involvement. Stage 1, head and neck. So the bilirubin level is 4 to 6 milligram per deciliter. It is just the estimation. Stage 2, upper trunk above the level of umbilicus, 6 to 8 milligram per deciliter. Stage 3, lower trunk and thighs. So bilirubin level is 8 to 12 milligram per deciliter. Stage 4, arms and lower legs. So extremities are involved. So bilirubin level is 12 to 15 milligram per deciliter, and when palms and soles are involved, then there is a severe jaundice. The bilirubin level is more than 15 milligram per deciliter. Now let's classify the jaundice. You all know prehepatic, hepatic and posthepatic. So prehepatic jaundice, the classic characteristic is patient is having anemia and jaundice. Both are present. Okay, and patient is having unconjugated bilirubinemia. The most common cause is hemolytic anemia. जो hemolytic anemia ना causes છે એ prehepatic jaundice ना cause આવશે. Hereditary sickle cell anemia, thalassemia, hereditary spherocytosis, elliptocytosis, some enzyme deficiency like J6PD deficiency, pyruvate kinase deficiency. Now acquired causes autoimmune hemolytic anemia, drug induced hemolysis, especially with the sulfa drugs, and antimalarials when we give in J6PD deficient patients, especially primaquine. Infections, malaria, sepsis, dengue, microangiopathic hemolytic anemia. It occurs mainly in DIC, TTP, HUS. Okay. Second is ineffective erythropoiesis, that is present in megaloblastic anemia when patient is having B12 or folate acid deficiency. Third is transfusion related, when patient is transfused with mismatched blood transfusion. So we check the compatibility for RH and ABO blood group. Second is hepatic jaundice. Hepatic in pre-hepatic jaundice, the enzyme is LDH is raised. Okay, while in hepatic jaundice, hepatic enzymes like AST and ALT are raised, and patient is having mixed picture of bilirubin. Unconjugated and conjugated bilirubin both are raised. Causes of hepatic jaundice, you all know: viral hepatitis A, B, C, D, E, even Epstein-Barr virus, cytomegalovirus, herpes simplex virus. Then the second most common is alcoholic hepatitis, though Gujarat is dry state, but અમે આ જ પેશન્ટો જોઈએ છે. Drug toxicity, especially એમાં બે હોય mechanism, એક idiosyncratic હોય અને એક dose dependent હોય. Dose dependent with acetaminophen, idiosyncratic with antitubercular medications like isoniazid, also valproate. Other drugs are methotrexate, phenytoin, statins. Now environmental toxins, that is wild mushroom consumption, vinyl chloride. Then the other common diseases are Wilson disease and autoimmune hepatitis, especially in females. This is a classic ochre yellow color of hepatic jaundice, right? Here you can see how to check for the jaundice. So ask patient to look downward and then retract both the eyelids. Okay, see the jaundice in unexposed part of sclera. Okay, because I have mentioned earlier, in exposed part you can find muddy sclera. So now see post-hepatic jaundice. It is also called obstructive jaundice. Jaundice, I mean the shades of yellow is greenish yellow. Why? Any idea? Lemon yellow, ochre yellow and greenish yellow here. So by the shades of yellow color you can identify the etiology of jaundice. Okay. Here the ALP and GGT, that is alkaline phosphatase and gamma glutamyl transferase, is out proportionately elevated than the AST and ALT. Few medical causes I have mentioned, otherwise it is called surgical jaundice. Primary biliary cholangitis, primary sclerosing cholangitis, cholestasis of pregnancy. Drugs, even drugs cause post-hepatic jaundice, cholestasis, that is chlorpromazine and erythromycin. Then surgical causes: choledocholithiasis, carcinoma of head of pancreas, cholangiocarcinoma, gallbladder carcinoma, choledochal cyst. I think surgery no thai gyu hase revision. You must be knowing all this. Now causes of isolated hyperbilirubinemia. Here the liver enzymes are absolutely normal. Only bilirubin is raised. So two types of bilirubin, direct and indirect. Direct is conjugated, indirect is unconjugated. So let's see the indirect hyperbilirubinemia. First you have to define what is indirect hyperbilirubinemia. When the direct fraction of bilirubin is less than 15% of total bilirubin, it is called indirect hyperbilirubinemia. The causes are same, that is hemolytic jaundice, ineffective erythropoiesis, then increased bilirubin production by massive blood transfusion or resorption of large hematoma. કોઈ એક્સિડન્ટ થયો હોય ને હિમેટોમા થયો હોય તો એમાંથી જે રિઝોપ્શન થાય ત્યારે બી બિલિરુબિન રેઝ થાય. ડ્રગ્સ: રિફામ્પિસિન, પ્રોબેનાસિડ, એટાઝાનાવિર, સેફેલોસ્પોરિન્સ. Now inherited condition, that is Crigler-Najjar syndrome, type 1, 2, 3, 4, Gilbert syndrome. The second is direct hyperbilirubinemia, there is a definition for it. We have defined it when the direct bilirubin is more than 20% of total bilirubin. And the causes are two. Only two causes are there: Dubin-Johnson syndrome and Rotor syndrome. Here I have summarized this table. So આમાં યાદ રાખવાનું એ છે કે ઓબ્સ્ટ્રક્ટિવ જોન્ડિસમાં સ્ટૂલનો કલર કેવો હોય? પેલ. ઓકે, and rest all we have learnt so far. Now let's see anemia. What is anemia? Anemia is a blood disorder characterized by the decrease in RBC mass or hemoglobin causing inadequate oxygen delivery to the tissue. So normal RBC production, let's see about it. What is hematopoiesis? It is a process by which RBC formation takes place. Okay. Now for the hematopoiesis, erythropoietin plays vital role. It is the main regulatory hormone. It is secreted by the peritubular capillary cells of glomerulus. Majority part secreted by it, and the small amount is secreted by the hepatocytes. Here I mentioned in brief, that is erythroid precursor is a pro-normoblast. After 4 to 5 days, 16 to 32 mature red cells are released. Now, what is the characteristic of mature red cell? It is 8 mm in diameter. They are anucleated. There is reticulocyte or nucleated. Discoid shape, extremely pliable. It is a disc shape. So it has more surface area, so it delivers more oxygen to the tissue. Average lifespan is 100 to 120 days. એટલે જ HbA1c 3 મહિના કરાવવાનું. Normal hemoglobin level, it is different for male and female, especially and also for specific situations like in pregnancy. In adolescent, it is a 13 gram per deciliter. Adult man, 16 plus or minus 2 gram per deciliter. Adult woman, 13 plus or minus 2 gram per deciliter. Postmenopausal woman, 14 plus or minus 2 gram per deciliter. And in pregnancy, it is a 12 plus or minus 2 gram per deciliter because of dilution. Okay, તો બધામાં એકનો એક આન્સર નહીં બોલવાનો એનિમિયા કે એટલે. These are the normal levels of hemoglobin. Grades of anemia: mild when the hemoglobin level is less than 10 gram per deciliter, moderate when hemoglobin level is 8 to 10 gram per deciliter, severe when hemoglobin level is 6.5 to 7.9 gram per deciliter, and life threatening means here you have to transfuse the blood. We cannot give oral therapy or parenteral iron supplementation here when hemoglobin level is less than 6.5 gram per deciliter. Now symptoms of anemia: patient complains of tiredness, easy fatigability, shortness of breath, palpitation, cognitive dysfunction means decreased alertness, memory loss, anginal pain in IHD patient. So ischemic heart disease वाला patient ने જ્યારે anginal pain થાય ત્યારે anemia rule out always કરવાનો. In fact, it is a type 2 MI, we can say. જ્યારે patient ને life threatening anemia હોય તો patient ને MI બી થઈ શકે. Headache, dizziness, symptoms of here I have specified symptoms of iron deficiency anemia. Patient is having craving for the non-nutritional substance like clay or ice. Clay ને કહેવાય પાઇકા, ice ને કહેવાય pagophagia. Patient is also complaining of restless leg syndrome. રાત્રે સૂઈ ના શકે patient. Symptoms of B12 deficiency. B12 deficiency, B12 is required for the myelination of nerves. So patient complains of neuropathic symptoms like paresthesia. Here loss of vibration and proprioception. So patient is having ataxia. Then SACD, subacute combined degeneration of spinal cord, where corticospinal tract and posterior column both are involved. Then optic atrophy. Patient complains of diminished vision. Then jaundice. As I mentioned earlier, it is an ineffective erythropoiesis. So jaundice is also present. Bruising. Why? Because B12 deficiency is having thrombocytopenia. એટલે bruising થાય. Then infection. In B12 deficiency, leukopenia is also there. So patient might have infections. Then dementia, even infertility and coronary artery disease. Now signs. Pallor, you all know. Pallor is seen in palpebral conjunctiva, nail bed, gums, soft palate, palms, tongue. Okay. Now, for iron deficiency anemia, you find platinacea. Platinacea is a flat nails. આપણે normal curvature હોય loss થઈ જાય. ઓકે, તો ફ્લેટ નેલ્સ હોય અને પ્લેટિનેકિયા કહેવાય. એ ઇનિશિયલ સ્ટેજ હોય, પછી જો ટ્રીટમેન્ટ ના કરે પેશન્ટ, ના લે તો પછી શું થાય? કોઇલોનેકિયા થાય. સો ઇટ ઇઝ અ સ્પૂન શેપ નેલ એન્ડ બ્રિટલ નેલ્સ. એન્ડ પેશન્ટ ઇઝ હેવિંગ બોલ ટંગ. ઓકે, નોર્મલ જે પેપિલાય હોય એ લોસ થઈ જાય. Then B12 deficiency. In B12 deficiency, we find knuckle pigmentation and beefy red tongue. Now, if patient is having life-threatening anemia, then patient may present with anemic heart failure. In that case, you find tachycardia, tachypnea, even bilateral fine crepitations in both lung fields because of pulmonary edema. Then flow murmur, as I think sir told, it is a functional murmur. And it is heard in all the areas of the heart. So here, just look at the picture. In the first picture, you can find koilonychia, brittle nails, and pallor in the nail bed. Second, palpebral conjunctiva. Always see like this, okay? When asked to demonstrate. ગમે ત્યાં રિટ્રેક્ટ નહીં કરવાનું, પહેલા પેશન્ટને ઉપર જોવાનું. ઇટ ઇઝ જસ્ટ રિવર્સ ઓફ જોન્ડિસ. ઓકે, આસ્ક પેશન્ટ ટુ લુક અપવર્ડ એન્ડ દેન રિટ્રેક્ટ બોથ ધ આઈલિડ્સ એન્ડ સી ધ pallor in palpebral conjunctiva. In the second picture, there is a knuckle pigmentation in B12 deficiency. It is a pallor in tongue. Okay. Now, classification of anemia. Max Winthrop classification of anemia. It is based on mean corpuscular volume, MCV. જે CBC નો રિપોર્ટ હોય એમાં RBC indices હોય, એમાં MCV is one of the part. So microcytic, normocytic and macrocytic. Microcytic anemia is seen in IDA, thalassemia, late stage of anemia of chronic disease, sideroblastic anemia and lead poisoning. Normocytic anemia, when MCV is between 80 to 100 femtoliter. It is seen in early AOCD, CKD, aplastic anemia, bone marrow infiltration like in leukemia, lymphoma, endocrinopathies, hypothyroidism, hypopituitarism, hemolysis and acute blood loss. Macrocytic anemia, that we have learnt the vitamin B12 and folate deficiency, also seen in alcoholism. Why? Because alcohol causes bone marrow suppression. Chemotherapy, anti-epileptic drugs like phenytoin, valproate leads to macrocytic anemia, myelodysplasia, even this anemia found in hypothyroidism. Now, which test to be done? CBC તો કરાવવાનો જોઈએ, એના પછી આગળ શું કરાવવાનું? CBC ઉપરથી તમને આઈડિયા આવે કે IDA છે, એટલે માઇક્રોસાઇટિક એનિમિયા છે, નોર્મોસાઇટિક છે કે માઇક્રોસાઇટિક છે. અકોર્ડિંગલી ફર્ધર ટેસ્ટ ઓર્ડર કરવાના હોય. સો ઇફ વી સસ્પેક્ટ આયરન ડેફિશિયન્સી એનિમિયા, દેન ગો ફોર સીરમ આયરન, સીરમ ફેરિટીન, સીરમ TIBC, percentage of transferrin saturation and red cell distribution width. So here I would like to mention about serum ferritin. Serum ferritin is a iron storage, right? If it is less than 30 microgram per deciliter, then it suggests decrease in iron store. But if patient is having anemia and raised ferritin, then what it is? Ferritin is inflammatory marker also. So it suggests anemia of chronic disease. Okay. Megaloblastic anemia. In megaloblastic anemia, patient is having pancytopenia. તો એના સિમ્ટમ્સ આગળ જોઈ લીધા, લ્યુકોપેનિયા, થ્રોમ્બોસાઇટોપેનિયા, HB તો હોય જ ઓલો. Then in peripheral smear, in peripheral smear you find megakaryocytes, basophilic stippling and hypersegmented neutrophils. Hypersegmented means more than 5 nuclear lobes. Then go with serum B12 level, serum folate level, serum MMA level, serum homocysteine level. MMA homocysteine એ આપણે દર વખતે નથી કરાવતા હોતા, but in special condition we do this. Now RD of, you must know about this. ખબર હોવી જોઈએ કેટલો ઇન્ટેક લેવાનો. RD of iron and B12, that is recommended daily allowance. For iron, male માટે 8 milligram per day, 8 milligram per day. For female it is 18 milligram per day. For pregnant woman it is a 27 milligram per day. And serum B12 we require in very little amount, 1 to 3 microgram per day. Now dietary sources you should know. What patient ને એડવાઇસ તો કરવી પડે ને, શું ખાવાનું. ઓલવેઝ પેશન્ટ પૂછે કે શું ખાવાનું હવે મારે, તો શું ઓફર કરશો. ડાયટરી સોર્સિસ એમાં બે હોય, હિમ આયરન એન્ડ નોન હિમ આયરન. હિમ આયરન that is it is absorbed, most of the heme iron is absorbed by the body, so it has high bioavailability. Okay. Meat, poultry, seafood. Non-heme iron it is a plant based, so જે આપણે ખાતા હોઈએ પાલક ને બધું લીફી ગ્રેન્સ ખાવાના, લેગ્યુમ્સ. ઓકે, બટ એની બાયોએબિલિટી બહુ ઓછી હોય છે. Absorption booster, ask patient to take this diet along with vitamin C. Okay, it helps in the absorption of iron. Absorption inhibitor, calcium and coffee, tea, coffee, beverages. Okay, because it contains phenols. Vitamin B12 rich diet, it is mainly animal based, but આપણી પાસે એક ઓપ્શન હોય ડેરી પ્રોડક્ટ્સ, I mean વેજીટેરિયન્સ માટે. બાકી તો મીટ, ફિશ and dairy products. Absorption site, that is most important. For iron it is duodenum, for B12 it is ileum. Now treatment. The mild anemia, mild to moderate anemia can be managed with oral iron therapy. Various compounds are there: iron sulfate, iron fumarate, ferric citrate. Usually we give in once or twice a day, but it has lots of side effect. Patient tolerate ના કરી શકે oral iron therapy. So એના side effect mainly GI side effect છે. Abdominal discomfort, nausea, burning, epigastric pain, metallic taste, diarrhea, constipation. Why? Because of toxicity of unabsorbed iron on intestinal mucosa. That is why GI side effect is more common with oral iron therapy. And it also changes the gut microbiome. So many patients are having infective diarrhea. So best regimen is alternate day iron salt with 80 ml of any vitamin C rich food. Then check for the increase in reticulocyte count within a week or rise in hemoglobin at least 1 gram. Okay, if it is not done, then it is a failure of therapy, and most common cause is malabsorption. Then patient should offer IV therapy. So IV therapy is indicated in patients who are intolerant to oral therapy, malabsorption, or we need rapid correction of anemia. The side effect is initially the iron dextran and that formulations are available which cause anaphylactic reaction, but nowadays newer formulations are available like FCM, ferric carboxymaltase. It has very less than 0.1% of anaphylaxis. So ઘણા ડોક્ટરો તો ખાલી ડે કેરમાં જ આપે છે, and it is given in within 15 minutes. 15 મિનિટમાં તો ઇન્જેક્શન પતી જાય અને પેશન્ટ ઘરે જતું રહે. Pernicious anemia, it is an autoimmune disease. The antibody present against intrinsic factor. We all know intrinsic factor is necessary for the B12 absorption, and it is deficient in gastric atrophy. Patient may have CA stomach, hypogammaglobulinemia, blue eyes. These are peculiarities of pernicious anemia. Patient may have blood group A. How to diagnose? serum antibody test કરાવવાનો against intrinsic factor and parietal cell of stomach. Also in this patient serum gastrin level is increased and serum pepsinogen level is decreased. Treatment is lifelong B12 therapy. And IV. We can give oral B12 also, but it requires very large amount of dose. Usually 1 gram to 2 gram microgram per day. Folate, when serum B12 level is normal, तो megaloblastic anemia हो serum B12 level कराई पर normal है, then always suspect folic acid deficiency and treat it with oral folate dose 5 to 15 milligram per day for 4 months. Before giving folate, rule out cobalamin deficiency. If you don't, then it worsens cobalamin deficiency. Okay. And if patient is on chronic dialysis, chronic hemolytic anemia, then lifelong treatment with folic acid is required. The other formulation or other compound for folate is folinic acid. It is stable and fully reduced form of folate. We give in methotrexate toxicity, folinic acid. Now this is the treatment of B12 deficiency. Usually, as I mentioned, oral require large dose. We give in IV or IM cyanocobalamin and methylcobalamin. Two compounds are available in India. Hydroxycobalamin is available in UK. Cyanocobalamin, that is synthetic, more stable, better for tablets and fortification of food. Methylcobalamin is active form. And the dose is per injection 1500 to 2500 microgram. First we should give loading dose. How to give? It is a daily for a week, then 2 to 3 times per week for a month, then once a week for a month, and then go with maintenance therapy, that is once in a month. Now let's start with clubbing. ક્લબિંગ તો આવડતું જ હશે. હવે થોડી શાંતિ થઈ ગઈ હશે ને કે આ બધું તો આવડે છે પહેલાના લેક્ચરો કરતા. Clubbing is also called Hippocratic fingers. It is a bulbous enlargement of distal phalanges due to increased soft tissue between nail plate and distal phalanx. Various theories exist for the clubbing. The most common and most accepted theory is PDGF. Here the megakaryocytes bypass lung because of the lung disease and right to left shunt, reach the fingertip vasculature, releasing PDGF and VEGF leads to increased vascularity, leads to connective tissue proliferation. That is how clubbing develops. Second theory is hypoxia theory. Chronic tissue hypoxia leads to vasodilation and opens AV shunts in distal phalanges, leads to tissue proliferation. Third theory is a neurocirculatory theory. Parasympathetic stimulation leads to vasodilation and leads to proliferation of tissue. Now how to grade the clubbing? A most commonly asked question in the exam. Stage 1 to 5. Stage 1 is fluctuation or spongy nail bed. So stage 1 clubbing હોય એમાં palpate કરવું પડે, જોવાથી ના મળે. Okay. Stage 2 is loss of Lovey-Burns angle. Usually Lovey-Burns angle is less than 160 degree. Here it becomes more than 180 degree. Third is increased curvature of nail. Fourth is drumstick appearance. Fifth is HOA, hypertrophic osteoarthropathy. Usually seen in CA lung. There are 3 methods for the clubbing. એક તો ખબર જ છે શામરોત સાઇન બધાને. ઓકે, યુઝ્યુઅલી ડાયમંડ સ્પેસ દેખાય પણ આમાં ઓબ્લિટરેટ થઈ ગયું હોય ક્લબ્ડ ફિંગર્સમાં. સેકન્ડ ઇઝ ડીપીડી એન્ડ આઈપીડી, distal phalangeal depth and interphalangeal depth. If the ratio DPD IPD ratio is more than 1, then we can say the fingers are clubbed. Second is hyponychial angle, that is Lovey-Burns angle. This is how we can measure the Lovey-Burns angle. The angle becomes more than 180 degree. Now causes of clubbing, આ બધું મોસ્ટ ઇમ્પોર્ટન્ટ, આ બધું આવડે ને એના પછી જ આ કોર એરિયાઝ છે તમારા. આ બધાના આન્સર કરશો એના પછી ક્રેડિટ ક્વેશ્ચન આવશે. ઓકે, so let's see the causes of clubbing. Pulmonary, lung cancer, bronchogenic carcinoma, bronchiectasis, cystic fibrosis, advanced stages of COPD, ILD. In cardiac, cyanotic congenital heart disease like TOF and transposition of great arteries. Eisenmenger syndrome. Eisenmenger syndrome, what is it? It is a reversal of shunt in VST and AST. Infective endocarditis. Third is gastrointestinal. In cirrhosis, advanced stages of cirrhosis of liver, hepatic carcinoma, inflammatory bowel disease, celiac disease, and GI lymphoma. Others are thyroid acropathy, or sometimes clubbings are familial. Now, unilateral clubbing, it is seen in aneurysm of aorta and its branches, brachial AV fistula and Pan-Cos tumor. Unidigital clubbing, it is found in tophaceous gout. Differential clubbing, only toes, spare fingers. So it is seen in PDA with reversal of shunt. Pseudo clubbing, it is seen in acroosteolysis, leprosy, hyperparathyroidism because of resorption of tissue. Now let's see cyanosis. What is cyanosis? It is a bluish discoloration of the skin and mucous membrane due to deoxygenated hemoglobin more than 5 gram per deciliter. Now let's see mechanism. Mechanism is absolute amount of reduced hemoglobin determines cyanosis, not percentage of saturation of oxygen. Okay, SpO2 ભલે 92 હોય પણ hemoglobin reduced હોવું જરૂરી છે, then only cyanosis we can see. In severe anemia we cannot see cyanosis, and in polycythemia cyanosis is more prominent. Now let's see the difference between central and peripheral cyanosis. Central cyanosis is seen in high altitude lung disease like pneumonia, COPD, ARDS, fibrosing alveolitis, right to left shunt, especially in pulmonary AV fistula, cyanotic congenital heart disease, advanced cirrhosis. Peripheral seen in shock, any form of shock, cardiogenic shock, septic shock, because it leads to hypoperfusion of tissue. Cold exposure, frostbite, and peripheral vascular disease. Mechanism in central cyanosis, it is hypoxemia, and in peripheral it is because of slow circulation. Sites where to see for cyanosis. Main clue is tongue. If the tongue is sinus, then it is a central cyanosis. Okay, and in peripheral cyanosis, ear lobules, fingers, toes, nail beds. These are the sites where you can find cyanosis. Skin is warm in central cyanosis and cold in peripheral cyanosis. Clubbing is present when there is a chronic cause of cyanosis. Response to ototherapy, the patients with central cyanosis respond to ototherapy. Okay, cyanosis will go. So now what is differential cyanosis? In which condition you can have it? Lower limb is cyanosed, upper limbs are normal. It is seen in PDA with reversal. Reverse differential cyanosis. તાનો reverse થઈ ગયું. Upper limbs are cyanosed more than the lower. So it is seen in PDA with transposition of great arteries. Localized cyanosis. It is seen in Raynaud's disease, scleroderma, and venous obstruction. Hemoglobin cyanosis. When patient is having methemoglobinemia, sulfhemoglobinemia, or carboxyhemoglobinemia, these are the hemoglobins, types of hemoglobins which are having high affinity for oxygen. So they don't release the oxygen. That is why patient develops cyanosis. Okay. So in that diagram you can see fingers are bluish. Here the cyanosis is seen in toes, fingers, and tip of nose. Now edema. What is edema? It is an abnormal accumulation of fluid in interstitial space. occurs when capillary filtration is more than the lymphatic drainage. Basic fluid dynamics ભણેલા જશો તમે physiology Starling forces. Main four forces are there: capillary hydrostatic pressure, interstitial hydrostatic pressure, plasma oncotic pressure and interstitial oncotic pressure. So the net filtration is outward minus inward forces. This is the whole heart of edema. આ diagram આવડેલી edema આવડી જાય. It contains everything from pathophysiology, causes. Let's see one by one. Increased hydrostatic pressure, that is seen in congestive heart failure and venous obstruction. Venous obstruction means yes, it leads to increase in capillary pressure, and that is why fluid shifts from the capillaries to interstitium, and that is how edema develops. Second is decreased oncotic pressure. Oncotic pressure is because of plasma proteins, mainly albumin. Okay, so whenever a patient is having hypoalbuminemia, you find edema. Okay, nephrotic syndrome and cirrhosis of liver, because albumin is synthesized in the liver. So that leads to edema. Third is increased capillary permeability because of inflammation, and it leads to leakage of fluids and proteins. That is how patient develops edema. Fourth is lymphatic obstruction. હવે interstitium હોય એમાંથી fluid drain કોણ કરે? Lymphatics કરે. When there is a lymphedema or lymph node dissection, અમુક સર્જરીમાં આપણે lymph node dissection થઈ ગયું હોય, કોઈને કોઈ ઘરમાં કદાચ થયેલું હોય, CA breast હોય તો એમાં શું કરે? Axillary lymph nodes બધા કાઢી નાખે. So patient develops lymphedema of arm. Okay. Also seen in lymphedema is also seen in filariasis. So, but in this, there is a peculiarity of this edema. Patient is having non-pitting edema. Okay. And the fifth is sodium and water retention. It is seen in chronic kidney disease or in AKI also. Okay. Now, pitting versus non-pitting edema. I hope you all have learnt it. Okay, from that slide. Non-pitting edema na બે cause છે, main hypothyroidism and lymphedema. Rest all જે આપણે discuss કર્યા, that all leads to pitting edema. As you see in the diagram, how to examine for the edema? Pressure should be applied against bony prominences and start from the distal, then go to proximal. Okay, તો જ્યારે બી edema ચેક કરવાનો કે ત્યારે મેલ્યુલાઇઝ હોય લોઅર લિમ્બમાં, એન્કલમાં, ત્યાં જ પ્રેસ કરવાનું, ગમે તે હાથ મૂકવાનો જ નહીં. and press for at least 15 to 30 seconds. પછી જ કહેવાનું છે કે નહીં edema. Okay. There is a pitting edema scale, grade 1, when there is a 0 to 2 mm indentation and rebounds immediately. Grade 2, 3 to 4 mm indentation, rebounds in less than 15 seconds. Grade 3, 5 to 6 mm indentation, up to 30 seconds to rebound. And grade 4, that is 8 mm indentation with greater than 20 seconds to rebound. Now anasarca na causes आई ज गया आगे. It is very logical. Okay, swelling of whole body, it is called anasarca. Congestive heart failure, nephrotic syndrome, cirrhosis of liver. Main 3 system involve થાય edema માં. કઈ થાય? હાર્ટ, renal અને liver. 3 system આપણે rule out કરવાની edema માં. Localized edema, unilateral leg swelling, that is seen in DVT, filariasis or chronic venous insufficiency like varicose vein. Painful edema, it is seen in cellulitis or trauma. This is how we can approach in the patients of edema. History ઉપરથી તમને ખબર પડી જાય પેશન્ટને કઈ સિસ્ટમનો ઇન્વોલ્વમેન્ટ છે. Accordingly, we order the test. I am not going in detail. But edemaની ટ્રીટમેન્ટ શું હોય? Foot elevation. પછી કયા ડાયુરેટિક્સ હોય? loop diuretics preferably, okay, and salt and water restriction. Lymphadenopathy, આનો યુઝ્યુઅલી કેસ આપણે મૂકતા નથી, બટ બ્રીફ તમને કહી દઉં. You should have general idea about it. Okay, so abnormal enlargement of lymph nodes, they are called lymphadenopathy. એના માટે normal size ખબર હોવી જોઈએ. Normal size of lymph nodes are cervical. For cervical and axillary group it is less than 1 centimeter. For inguinal it is less than 1.5 centimeter. Can you see lymph nodes in anterior cervical region? These are the various groups of lymph nodes: preauricular nodes, submandibular nodes, anterior cervical nodes, posterior cervical nodes, supraclavicular, infraclavicular, axillary, epitrochlear, inguinal. The classification localized or generalized. Localized હોય તો એનો ડ્રેનિંગ એરિયા હોય ત્યાં જ કંઈક પેથોલોજી હોય, અને generalized હોય તો rule out malignancy, lymphoma, Hodgkin's lymphoma or non-Hodgkin's lymphoma. Based on duration, it is acute, subacute or chronic. Infectious cause. In India, the most common cause of cervical lymphadenopathy is tuberculosis. It's a dictum. Other bacteria also leads to lymphadenopathy. Strep. Patient at tonsillitis હોય તો submandibular બધા lymph node enlarged હોય. Okay, because they are the draining lymph nodes for that area. Virus, Epstein-Barr virus infection, HIV, even toxoplasmosis. Miscellaneous cause, systemic lupus erythematosus, rheumatoid arthritis, sarcoidosis, Kikuchi disease. I'm not going in. This is how you should palpate the lymph node. Okay, for neck, cervical lymph nodes, stand behind the patient. Just mild flex the neck, relax the muscle, okay, and start palpating lymph nodes. For axillary lymph nodes, outstretch patient's hands and rest on your hand. Okay, then start palpating axillary nodes. Palpation માં શું જોવાનું? કરતી વખતે શું જોવાનું એ બી ખબર હોવી જોઈએ ને. બોલો. Consistency, yes. Consistency ઉપરથી disease diagnose થઈ જાય. Okay. I think દેખાય છે? Okay. When the lymph nodes are tender, the etiology is infection. When they are rubbery, the etiology is malignancy or lymphoma. When they are matted or conglomerated, the etiology is tuberculosis. Now, what is Virchow's node? Supraclavicular node because of, it is because of metastasis from the CA stomach, right? Investigations, બસ હવે આ તો રૂટીન જ છે. Now આમ તો જેકોલોજ હતું, but I would like to go for few slides for general examination. જે most common asked question હોય છે. They are phases in medicine. Now identify different phases. First is hypothyroidism, hypothyroid phase. Second is leonine phase, seen in leprosy. Third is Alpine phase. Fourth is moon phase, seen in Cushing-White syndrome. Fifth is cirrhotic phase. Cirrhotic phase એટલે એમાં શું હોય? પેરોટિડ એન્લાર્જમેન્ટ હોય અને આ બધું બકલ ફેટ લોસ થઈ ગયું હોય, એલોપેશિયા હોય, ટેમ્પોરલ વેસ્ટિંગ હોય. Chipmunk phase, that is seen in thalassemia. Face in SLE. SLE માં શું હોય? ડાર્ક સ્કિન છે એટલે યુઝ્યુઅલી આપણને એટલું ના દેખાય, જે વ્હાઇટિશ પીપલ એમાં તરત જ દેખાય, બટ ઇઝ અ બટરફ્લાય રેશ. હાઇપરથાઇરોઇડ ફેસ, આંખ ઉપરથી ખબર પડી જાય, ગ્રેવ્સ ઓપ્થેલ્મોપેથી. નેફ્રોટિક સિન્ડ્રોમ. નેફ્રોટિક સિન્ડ્રોમમાં શું થાય? પ્રોટીનુરિયા થાય એટલે હાઇપોઆલ્બ્યુમિનેમિયા હોય, એટલે શું છે? પેરીઓર્બિટલ ઇડીમા છે, ઇવન આખો ફેસ જ સ્વોલન છે. દેન સ્ક્લેરોડર્મા, fish mouth appearance, skin આખી ટાઇટન થઈ ગઈ હોય. પાર્કિન્સન ફેસ, mask like face હોય, without any expression. And Bell's palsy. Okay, and Bell's palsy, angle of mouth is divided towards same side. Okay, એ યાદ રાખવાનું. જે નોર્મલ સાઈડ હોય એ જ મસલ એને પુલ કરે, એટલે પાલ્સી ઓપોઝિટ સાઈડ હોય. Now skin in medicine. These are cafe-late spots seen in neurofibromatosis. The pellagra, Cazel's necklace. Scabies, herpes zoster, chicken pox, DIC rash. DIC એટલે ખબર છે ને શું? યસ, તેમાં શું થાય? પરપ્યુરા થયા છે જુઓ. SLE જે કીધું એ મલાર રેશ, IgA vasculitis and pitakin, dengue and TTP. These are the stria Cushing or in Cushing disease. And then leprosy, depigmented macules છે. Then calcinosis cutis, it is seen in અને કયો syndrome? Acanthosis nigricans, it is seen in insulin resistance, diabetes. Now posture. What is posture? Position of body while sitting, standing or moving to maintain the balance. So from the posture we can diagnose the disease. Patient ત્યાં હોય ને ત્યાંથી ખબર પડી જાય કે આને આ disease છે. And what is decubitus? Decubitus તો કીધું ને હમણાં. શું હોય? Posture assumed by on lying down position. So these are the various postures. First is stooped posture in Parkinson disease. Second is hemiplegic posture. Third is lordotic posture seen in muscular dystrophy. Fourth is decerebrate and decorticate rigidity. Decerebrate means widespread insult in cerebral hemisphere. And decorticate is lesion at the level of brainstem or below. Then opisthotonus seen in tetanus. Then tripod position. Tripod position is seen in exacerbation of COPD, asthma or pulmonary edema. Fetal position seen in meningitis. Then these are the decubitus, mainly left lateral decubitus. It is seen in pleurisy because patient feels better when lying on the same side. It reduces the friction of pleura, visceral and parietal pleura. And orthopnea. Orthopnea તો ભણી લીધું ને. Now tongue in medicine. First is pallor, atrophic glossitis, oral thrush, that is candidiasis, fissure tongue. It is seen in Down syndrome or Rosenthal syndrome. This cyanose tongue. The patient is having central cyanosis. There is a strawberry tongue seen in Kawasaki disease. Then macroglossia. Macroglossia is seen in acromegaly. And last one is beefy red tongue. It is seen in various vitamin deficiency like niacin, pyridoxine and B12. Thank you and good luck. All the best for the exam.
On behalf of Ahmedabad Medical Association, I am very much thankful to all the faculties who have arranged this grand revision of your all medicine in very few minutes on very short notice. I am very thankful to all of you. Madam, no, એક તમારો મોમેન્ટ આપું છે. ડોક્ટર સોનાલી મેડમ ને રિક્વેસ્ટ કરીશ કે હા પ્લીઝ.
So we are thankful to Dr. Sonali for teaching us neurology. And very nicely. Okay.
લેક્ચર બાકી છે.
થોડું જલ્દી બતાવીશું. Have some patience. હજી રેસિપી બાકી અને ટેબલ વાયવા.
Just bear us at least for half an hour from now. Respi system in very short will be again be taken by ma'am Sangeeta ma'am, and Dr. Ibrahim and Dr. Dhwani will take lectures for your table viva. Right, we have divided it into ECG, X-ray as a different part, and the other parts, drugs and instruments, as others. Very shortly, they will be completing it. Don't worry. Okay, don't sleep.
હા મારો જ છે રેસ્પી ચાલુ કરો ના મારો જ છે તમે ચાલુ કરો
કયો છે તમારો
સોરી રેસ્પી સિસ્ટમ એટલે કોઈ બી એક ખોલો ને તો ખબર પડશે કયો છે હા બસ
So, let's start respiratory system examination. As the time constraint is there, I will take very fast. But the important points during the examination, what is important, I will call one or two volunteer to demonstrate. I do have the figure, but let us do practical also. So in respiratory system, the symptomatology, the cough, again, acute onset cough, chronic onset, the causes are different, acute, any upper respiratory tract infection, pneumonitis, pleurisy, everything. Chronic cough, most common is tuberculosis. Then it may be in the COPD, in chronic bronchitis, or in the malignancy of the lung. What is the color of the sputum? We can little bit differentiate the etiology. If it is whitish, sticky sputum, difficult to expectorate, commonly found in the bronchial asthma. If copious amount of the sputum is there, commonly because of the lung abscess or bronchiectasis with the secondary infection. Greenish sputum is there, so infection with the pseudomonas organism is common. If rusty sputum, rusty એટલે little bit brownish, so it is commonly found in pneumonia. Anchovy sauce colored, okay, in the lung amoebic infection. Amount is scanty or copious, as I told. Hemoptysis, we have already discussed, that is the blood in the cough or blood in the sputum. The common causes are again tuberculosis, the most common cause. Second common cause is severe bronchitis. Sometimes the tuberculosis is not there. Severe bronchitis can also produce a blood stained sputum. Then malignancy, again bronchogenic carcinoma produces the hemoptysis. If patient is on some drugs like anticoagulant drug, then also there is history of hemoptysis. And in cardiovascular system, pink frothy sputum because of the left ventricular failure in patients of the mitral stenosis. Okay. Whether there is any relation to the posture, cough માં decubitus તમે હમણાં જ ભણ્યા respiratory condition વાળા patient કયું decubitus લે? Same side, because they will feel that there is less cough in this side rather than the opposite side. Expectoration is better for them, but they will assume the same side posture to get the relief from the cough or pain. And what is spurious hemoptysis? Tell me. Spurious, S-P-U, spurious hemoptysis. Spurious hemoptysis credit question is there. What is it? Whenever there is an blood coming from the upper respiratory tract is collected into the throat and is expectorated, then it is called spurious hemoptysis. The lower respiratory tract is absolutely normal. Okay. So you have to ask in detail about the cough. Associated complaints will guide you to the possible differential diagnosis. Breathlessness, important part. You have already learned in the CVS system examination, but respiratory origin breathlessness is having, you have to ask whether it is acute onset or chronic. It is since long, and whether it any worsening recently at rest or on exertion. What is about the diurnal variation? This is important. You know about the PND, paroxysmal nocturnal dyspnea, one-liner question. In asthma also there is diurnal variation. Patient will have
breathlessness more in the early morning. Seasonal variation. Patient who are having a history of allergic diseases, allergic asthma or allergic bronchitis, there is usually a seasonal variation. Whether it is relieved with rest or after expectoration and other complaints. NYHA grading is for cardiac breathlessness. Now tell me, how will you grade the respiratory origin breathlessness? તમે બોલો રેસ્પીના કેસમાં બી breathlessness બોલો ત્યારે એમ કહો NYHA grade 2. So RESPI you have had different classification. The two classification we use, that is an MRC classification and the Sherwood-Jones classification. So this is about the MRC classification, Medical Research Council classification of breathlessness. Okay. Grade 0 is breathlessness on strenuous exercise. Grade 2 is walking not on normal pace, hurrying or up the hill. Grade 3 is compared to the other people of the same age group, they walk slowly and they have to stop in between. So the grading are from 1 to 5. Chest pain. It's majorly cardiac origin. But respiratory origin chest pain, you have to differentiate. How? एक तो location. Cardiac origin breathlessness is left-sided. Respiratory origin can be left or right. Again cardiac, it is heaviness or feeling a crushing sensation. In respiratory, it is a sharp, knife-like. And most important part, you have to remember that it aggravates while coughing, sneezing or yawning. Okay? It occurs because of the friction between the inflamed pleura. Hemoptysis we have already discussed. So in examination, when you tell that on inspection, palpation, percussion or auscultation, you have to speak in the area wise. Okay. Lung ne apne anatomically divide kariye to is different thing. With the transverse fissure and oblique fissure, the right lung is divided into the 3 lobes, left is divided into the 2 lobes. It's okay. We are not telling about the zone, upper zone, mid zone, lower zone, no. That is, zone should be described in the X-ray, that the consolidation is seen in the upper zone, mid zone or lower zone. But in examination, you have to say according to the areas or the regions, that is in supraclavicular, clavicular or infraclavicular, mammary region, inframammary. In axilla, axillary, there is no supraaxillary. Okay. So again I repeat, supraclavicular, infraclavicular, mammary, inframammary, axillary, infraaxillary. In the front. In the back, we will see scapular, interscapular, infrascapular. This is the anatomical landmark. Now on inspection, again like GI, oral cavity examination, here upper respiratory tract examination, the nose, nasal cavity, deviated nasal septum. Important thing in the case of pneumonia, if there is patient is having a breathlessness, you have to notice the movement of L-nasal. Okay, L-nasal suggests there is an respiratory distress. Breathlessness is severe and it is an accessory muscle of respiration. Okay, so L-nasal. Best position for respiratory system examination is sitting or semi-reclining position, not in complete supine. If your patient is able to sit, ask him to sit for examination. Movements of hand as and when required should be changed. Like for axillary region examination, I will do what? I will ask what patient to do the movement. Put your hands on the head so that the axillary portion is exposed and I can better examine axilla. For the back, I will ask the patient to do this so that the back is examined nicely. For the front, the hands by the side is okay. Okay. So in inspection, shape of the chest, bilateral movements, equal or not, rate of respiration and the type of breathing, trachea whether it is central or not, that is called trail sign, apex beat in inspection, in palpation, in both and in auscultation also. Skin and veins over the chest wall if any abnormality, back and spine. So inspect for the symmetry of the chest. You know Normal shape of the chest is elliptical. Okay? એટલે શું? AP and transverse diameter if we take, we are not supposed to take in the inspection. But if we take AP and transverse diameter, usually what is the transverse diameter is more than the AP diameter. The ratio is 5 to 7. The ratio is 5 to 7. But if this ratio is altered in many conditions, let's see. Flat chest, the AP diameter to transverse diameter ratio is 1:1. Barrel shaped chest commonly, આપણા બધા પેશન્ટ જે મૂકે COPD ના એક્ઝામમાં બેરલ શેપેડ ચેસ્ટ એટલે શું? આખી ચેસ્ટ ગોળ થઈ જાય. એપી ડાયામીટર ટ્રાન્સવર્સ ડાયામીટર નિયરલી સરખો થાય. ઘણીવાર તો એવું થાય એપી ડાયામીટર વધી જાય ટ્રાન્સવર્સ કરતા. That is an barrel shaped chest. Common finding in patients of emphysema. Okay, you can see the picture. Pigeon chest, it is also called as an pectus carinatum. It's a forward protrusion of sternum and adjacent costal cartilages. It is seen in Marfan syndrome, childhood asthma and rickets. Pectus excavatum, that is a funnel chest, or it is also called cobbler's chest. Cobbler આમ એનું પેલું શું કહેવાય એને લઈને બેઠો હોય ને એના લીધે અહીંયા compression આવે non-stop. If he is doing since long, the lower part of the sternum is depressed, and that is why the name is given cobbler's chest. It is an exaggeration of the normal hollowness over the lower end of the sternum. It's a developmental defect. The apex bit is shifted further to left and ventilatory capacity is also restricted. It is seen in Marfan's syndrome. Harrison sulcus again in rickets. There is an indrawing of ribs with horizontal groove at the costal margin. Rosary, two type of rosary you have learnt in the pedias, scorbutic rosary, ricketic rosary. One is tender, one is non-tender, this. Kyphoscoliosis, again it's a spinal deformity. Why it is important in respi? Because it limits the lung ventilatory capacity. Unilateral swelling of chest wall or intercostal spaces તમને દેખાય. Massive effusion હોય તો તમને mild લેફ્ટ સાઈડ કરતા રાઈટ સાઈડ ધારો કે ઇફ્યુઝન છે તો ઇન્ટરકોસ્ટલ સ્પેસીસમાં ફૂલનેસ દેખાય એન્ડ લિટલ બિટ બલ્જ ઇઝ ધેર. બાકી તો રીપ કેજ છે એટલે અંદર એટલું બધું ના થાય. અને રિટ્રેક્શન ઓફ ધી ચેસ્ટ વોલ સમટાઇમ્સ કેન બી અપ્રિશિએટેડ ઇફ દેર ઇઝ ગ્રોસ ફાઇબ્રોસિસ, કોલેપ્સ ઓર હિસ્ટ્રી ઓફ પલ્મનરી રિજેક્શન. હાઉ ટુ ચેક ફોર ધી bilateral equality of movement? You people do many a time mistake during the examination of this. So, may I ask two volunteers to come here? Bilateral equality of, વિચારી લો કોણ આવે ત્યાં સુધી, નહીતર પછી હું કોઈને કહું. Observe from the foot end of the bed. Here it is an inspection, not an palpation. From the side at the chest level or from the foot end, both part of the chest should go up and down equally. Ask the patient to take deep breath. Bilaterally diminished in emphysema and paralysis of respiratory muscle. If it is unilaterally diminished, then the pathology is on that side. Normal chest expansion during full inspiration is nearly 5 cm when we take the diameter, not right now. And if abnormal indrawing of intercostal spaces is there, you have to notice. The rate of respiration normal, 12 to 16 per minute, just going fast. Tachypnea is what? Increased rate of respiration. Dyspnea is what? Difficulty in breathing. The respiratory rate is increased, but patient is also aware. In tachypnea, patient may not be aware. The rate of respiration is increased. Hyperventilation, the rate is also increased. The depth of respiration is also increased. Bradypnea, decreased respiratory rate. Orthopnea, again we already discussed. Platypnea, the breathlessness is in sitting or standing position and patient will feel better in the lying down position. It is a special situation in which there is orthodeoxia. The causes are the congenital heart disease and many. And Kussmaul's breathing. Kussmaul's breathing you all know. It's a rapid, shallow breathing observed in patients of the acidosis due to the any cause. Commonest is the diabetic ketoacidosis. So the etiology is there for all. Type of breathing, again we have discussed thoracoabdominal, abdominothoracic, Kussmaul's. What is Stokes breathing? There is apnea, hypopnea, hyperapnea, and there is a cyclic breathing rather. Okay. Apnostic breathing and irregular breathing is Batot's breathing. Many causes are central conditions. Here it is the same mentioned. Trail sign. That is, trail sign is what? If the trachea is shifted to one side, the trail sign is positive. Trachea is central or not. How to see? It is also called as a sternocleidomastoid sign. Patient is there. Just see the two clavicular head of the sternocleidomastoid muscle. Ask the patient to flex little, to extend neck little bit and see the prominence of these two clavicular head. The side, the clavicular head more prominent is the side where the trachea is shifted. Why? Because these two heads and the trachea, these all are covered with the pretracheal fascia. The trachea આમ shift થાય because of any pathology. એ pathology આપણે ભણીએ તો શું થાય? This pretracheal fascia on this side is little bit released. આ બાજુ shift થાય એટલે અહીંયા જે fascia tense હોય એ આ બાજુ release થાય. Release થાય એટલે આ clavicular head becomes more prominent. Okay. So, what are the causes of the trachea shift on the same side? Collapse, fibrosis and pleural adhesions. And in opposite side it pushes, pull and push. It pushes to the opposite side like in pleural effusion, pneumothorax, hydropneumothorax. Because of the mediastinal shift, along with the mediastinum the trachea is shifted. This is the sign, trail sign in the picture. See, the left sided clavicular head is more prominent. So the trachea is shifted to left. Also notice about the position of the apex impulse if it is visible. Inspection ma. Normally visible in fifth intercostal space just inside the midclavicular line. It is again shifted sometimes in the pleural effusion. If I have the pleural effusion on the left side, then it may compress the heart and little bit shift of the apex bit is there. What is Lytton sign? It is for the seeing the contraction of the diaphragm. Again it's a credit question. Contraction of the diaphragm is present or not. It is seen from the light which is passed from the foot end of the bed, and the examiner will stand on the side, and the light's shadow I will see. It is moving up and down. If this shadow is not moving, then it may be a condition in pleural effusion, pneumothorax or hepatic abscess, or there is a paralysis of diaphragm. Skin over the chest, you have to notice any scar is there, any sinus draining is there, any dilated veins are there, etc. etc. Now comes the palpation. So in inspection what we have seen? The shape of the chest, bilateral equality of the movements, then apex impulse if it is seen, trachea central or not, skin over the chest wall, any scar, back and spine. That's it. And respiratory rate again, never forget. Palpation. How to speak palpation? So, on palpation, I will confirm my inspiratory findings like the trachea is central, chest movements are bilaterally equal in the front and at the back. Okay. I will also take the AP and transverse diameter. I will speak. Apex bit, if palpable, where it is. Tactile vocal fremitus, what is it? Yes, patient will speak 1, 2, 3 or 1, 1, 1. You will place your hand with the ulnar border starting from the second intercostal space. You will ask the patient to speak 1, 1, 1, 1, 1, 1, 1, 1, 1. પછી તમે શું કરો છો? What mistake you are doing? નીચે જાઓ છો, third intercostal space. No. Both the sides intercostal spaces should be examined simultaneously. આ બાજુની second, આ બાજુની second, આ બાજુની third, આ બાજુની third. Okay? So the shape of the chest and measurement of the AP and transverse diameter, bilateral equality of movement, tracheal position, apex, big T, VF, and if there is any local tenderness, palpable pleural rub, etc. etc. Surgical emphysema હોય તો તમે surgery ભણ્યા મૂકો એટલે velcro craps feel થાય. We have already discussed chest expansion, hemithorax expansion, sometimes in pathology like gross pleural effusion, pneumothorax, hemithorax diameter ક્યાંથી લેવાનો? Mid sternal line થી mid spinal line સુધી. એ કોઈ વાર કોઈ પૂછે તમને. This is a method how to take the AP diameter, transverse diameter and how to examine for the chest expansion. શું કરવાનું? You have to take two cartoons, okay? For the AP diameter, you have to place two cartoons here. And for the transverse diameter, you have to put the cartoon like this and measure the distance, okay? Here? Yes. So AP and transverse diameter should be taken like this. Chest expansion. With the measure tape at the level of nipple, you cover the whole chest with the measure tape and first ask the patient to fully go for the expiration. Then ask the patient to take deep inspiration and see how much chest is expanded. Usually it is more than 5 centimeter. Okay, if it is less, the movements are less. See, I have shown you that examination of AP diameter how to take and chest expansion. Bilateral equality of movement કેવી રીતે ચેક કરવાની? Yes, કોઈ આવશો? See, the figures are there, you people have, but how to do? Just see once so that you do not commit any mistakes during exam. He is visible to everyone, eh? Okay. So examination of for the equality of the movement, it is done both in the front and at the back. All regions we have to mention. Put the fingers in the intercostal spaces. Okay. Supraclavicular region is checked from behind, not આમ ગળા ઉપર હાથ નહીં મૂકવાનો. Infraclavicular, mammary and inframammary region. How to put? I have already shown in the figure. Let me demonstrate. For infraclavicular, sometimes like this. You have to put your hand like this. આ જે છે chest wall ને ચોંટી જવી જોઈએ fingers. For mammary, I will put my fingers in the intercostal spaces. I will hold whole chest and I will oppose my thumbs together. And for inframammary, I will put my these borders parallel to the coastal borders. I will hold whole chest and I will do this and then ask the patient to take deep breath. Okay. This is for the front. For the back. From back, I will go for the supraclavicular region examination also. Like this. This hand will be in the supraclavicular regions and thumb will oppose at the C7. Okay. Then suprascapular. Scapular. Infrascapular. Okay. So this is the method. You can go. Thank you. So at back, tips of the fingers should be at C7 or D1 vertebrate level. I have demonstrated in the figure. And for infrascapular region again, the figure is there. Notice which hand is moving less. The pathology is on that side. Remember this. So, increase hemithorax size and decrease movement in pleural effusion and pneumothorax. Decrease hemithorax size and decrease movement. Fibrosis and collapse. Normal size but still movements are decreased. It is in consolidation because of the pain. Palpation of trachea again. One finger method, two finger method. How to go? One finger method. Again, ask the patient to extend neck little bit. Palpate the tracheal cartilages and trace it downwards. Whether you are able to trace it normally or not. If it is deviated, you may not. One side it will be hollow. Two finger method again important. How to go? These two clavicular heads are there. Visible to everyone. thumb and index finger, one will be inside, one will be outside. Okay, clavicular head, thumb एक बाजू बाहर, एक बाजू index finger अंदर. Take the distance. Same opposite, take the distance. Both are equal or not. Along with it, also feel your index finger indentation. Whether it is bilaterally equal indentation is there or not. Indentation, if it is difficult, then the trachea is shifted to that side. So two finger method to see the measurement as well as the indentation, which is easier between the thumb and this side, where the distance is less and indentation is difficult, the trachea is shifted to that side because of the relaxation of the pretracheal fascia. This is a method, one finger and two finger method, and third figure is feeling for the indentation. Again a credit question, what is the Oliver's sign? You can read. Campbell sign. Apex beat, again with the palm or with the fingers you have to palpate in the intercostal space, 5th or 6th or 4th intercostal space. But when you are able to locate, then with the tip of the finger you have to see the character and many other things for the apex beat. You have already learned in the CVS. TVF, I told, check simultaneously all the intercostal spaces for the axillary. Why the TVF is, in which conditions it is increased and decreased? It is increased in consolidation, large cavity and bronchopleural fistula. It is decreased in pleural effusion, pneumo, fibrosis, collapse, asthma, emphysema, thick pleura. In consolidation, the alveoli are full of exudates. So the transmission of the sound is directly from the bronchi. That is why the TVF is increased. In cavity, the vibrations are directly transmitted to the chest wall because there is no intervening lung tissue, and that is why TVF is increased. In pleural effusion, pneumothorax, there is air, there is fluid in between, and that is why the TVF is decreased. Tenderness over the chest wall, if it is there. Percussion, direct percussion and indirect percussion. Direct percussion is done on the clavicle and the sternum, and what we are doing is indirect percussion with the plexor and pleximeter finger. Percussion again is done in the anterior chest, in the axilla and the back areas. The position I have already discussed. Remember, plexor and pleximeter finger, how to use the percussion should be at least 2 to 3 stroke. The movement should be free at the wrist. This is a direct percussion for the clavicle. Okay. This is indirect percussion. Locate the second intercostal space, put your finger firmly in the intercostal space and give a stroke. So, percussion on the anterior chest, in the axilla and at the back. See the position of the hands in the patient like this, and then percussion of the back is done. Noting of various notes. Pleural effusion માં dull note આવે, તમારા કેસમાં pleural effusion હોય તો, અને the note is impaired in patients of consolidation. Tympanic note, it is just like a drum-like note. Usually when you percuss the Trout's space, that note is tympanic. Hyperresonant is in emphysema and pneumothorax. Large cavity or bulla. Resonant is normal. નોર્મલ કયું છે એના માટે તમારે તમારા ફ્રેન્ડમાં પરકશન કરીને પ્રેક્ટિસ કરવાની. પણ હવે ચાલે 2 દિવસમાં જેટલી થાય એટલી. Impaired in consolidation, fibrosis, collapse and dull note is in the pleural effusion. Also notice that the hepatic dullness and cardiac dullness is there and it is not pathological. Okay, some other things are there. Just only of theoretical importance, we just really ask, you have to remember, that is crackpot resonance, amphoric breathing, bell tympani, etc. etc. Chronic isthmus, what is it? It's a band of resonance on the lung apex. એવું કહેવાય કે clavicle supraclavicular region માં, supraclavicular region, both the side there is an dullness, but here in the center there is resonance. If this resonance is replaced by dull, then it suggests the lung apex pathology. Okay, that is why this is important. It is a band of resonance in supraclavicular area bounded anteriorly by Posterior border of clavicle, medially by neck muscle and posteriorly by trapezius border. Stand behind the patient, place the pleximeter finger over the neck, percuss from lateral to medial, and there is a dull zone medially and laterally. In between there is resonance. Apical tuberculosis, Pankos tumor or apical fibrosis will replace this resonance to dull. This is a method how to check for the chronic xysthomas. Tidal percussion, the percussion in the respiration. Subpulmonary or subpleural pathology માટે tidal percussion is important. Ask the patient to take deep breath. Fifth intercostal space માં તમે percuss કરો, પછી patient ને deep breath લે, again percuss. This is the method how to go for the tidal percussion and percussion of the trough space. Ellis shaped curve in the pleural effusion. Garland's triangle, Grocos triangle, these all are credit questions if you know. This is a figure which is showing the pleural effusion with the Grocos and Garland triangle. It occurs, there is a resonance just near the area of the pleural effusion because of the relaxation of the lung tissue near there. The borders are there, you have to remember. Auscultation, what points? Breath sounds. Vesicular, normal. Bronchial, normal on the trachea and near sternum. Bronchovesicular, okay. And check for the vocal resonance. Vocal resonance is nothing but it is same like the TVF, what we have seen in the palpation. Vesicular breathing, again you note the characteristics. The inspiration is longer, expiration is 1/3 of inspiration, no pause. Bronchovesicular, both are same and no pause. Bronchial, inspiration is shorter, expiration is longer and there is a pause in between. Just do one thing, take a statho, put on your lung area, auscultate in a calm environment and then put the statho, auscultate the trachea. This is vesicular, this is bronchial, you will know. But if bronchial breathing comes in the lung area, then it is pathological. So vesicular breathing I have already described. It is decreased or absent in obstruction to the trachea if upper airway obstructed or pneumothorax or pleural effusion. The breathing is heard less, thick chest wall and obesity. Bronchial breathing, I have described the characteristic: short inspiration, pause and long expiration. It is blowing or high pitch. It is found normally over the areas of trachea and near the sternum. Abnormal if over the lungs in consolidation, cavity and partial collapse. Again there are subtypes. You people may not differentiate. You differentiate vesicular and bronchial, then it is also more than enough. But it is given in the book amphoric, cavernous, tubular. But remember this point. Bronchial breathing, if found on the lung, it is always associated with the increased vocal resonance. Okay. Bronchovesicular, asthmatic, cogwheel breathing, puerile breathing, these are the various types of the breathing. Adventitious sound or foreign sound, you know, the crepitations, rhonchi, wheeze, pleural rub, succussion splash, bell tympani, etc. Crepitations are what? These are the moist sound which are heard because of what? The alveoli or the bronchi are full with the secretions and the air is passing through the secretions to પરપોટાની જેમ અવાજ આવે. Crepitations may be coarse, it may be fine, it may be velcro like velcro ખોલી અને કેવા અવાજ આવે એવું. That is characteristic of interstitial lung disease. Coarse crepitations in consolidation, fine crepitations are there in the pulmonary congestion. Rhonchi is what? It's a dry musical sound because of the air passing through the narrow air passages due to the edema or spasm, asthma ma ave. And it is termed as wheezing if it is audible without statho or audible to the patient sometime. It is seen in the asthma, bronchitis, COPD or chemical or respiration pneumonitis. Again the types are there: sibilant rhonchi, sonorous rhonchi. It can be monophonic, it can be polyphonic. Rub, pleural rub. It's a dry, grating sound due to the friction between the two inflamed layers of the pleura. It indicates the pleurisy in tuberculosis, pneumonia or pulmonary infarction or malignancy of the pleura. It may be sometime palpable. Bell tympani, okay, it's a coin toss, nobody expect. Vocal resonance, like TVF performed with the stethoscope. It is an auscultatory form of the TVF. It is increased. Again, I repeat, consolidation, cavity, and collapse. The types of the vocal resonance is bronchophony, egophony, whispering, pectoriloquy. Again, it's a theoretical question. What is bronchophony? That is a clear sound as if spoken at the ears, if it is audible. Egophony is nasal twang. Whispering, pectoriloquy, you can, in the cavity and consolidation, so much increase that even patient whispers, then it is clearly heard at the stetho. And the vocal resonance is decreased in pleural effusion, pneumothorax, fibrosis, emphysema. That's it. Thank you. The main thing is method of examination, because when you are asked to demonstrate, never ever do any mistake. That's it. Okay? Theory તો તમને કદાચ મારા કરતા વધારે આવડે. So best of luck. Next, table viva.
A very good afternoon, everyone. Already tired? Okay, I'll be taking the most scoring thing, that is the table vivas and the X-ray ECGs. Okay, I'll circulate some X-rays. खोलो तो खरा.
हेलो કયું છે તમારું હા
Best luck બતાવો નીકળો. હું નીકળું. બહુ મોડું થશે હજી ઘરે જઈને.
ખાલી અમને કહી દે કે 30 મિનિટ થશે બંને વસ્તુ પતાવતા તો 15 મિનિટમાં ઉડાડો.
So, starting with the basics first, different tissues in our body absorbs X-rays differently, okay? So, air will be able to pass the X-ray radiations very clearly. So, it would be the least opaque one, and so all the air tissues will be radiolucent. Then comes the fat, then comes the soft tissue, then comes the bone, and the metal being the most opaque thing. So there are 4 major views, and most probably on your table vivas only the X-ray PA view and an AP view must be kept. Lateral and lateral decubitus views are mostly not kept. Okay, so in a PA view, as the name suggests, posterior anterior view, here the rays come from the posterior side and the metal plate is anteriorly placed. So all the anterior organs will be seen very clearly. Then comes the AP view. Here the patients who are too ill to stand or who are non-cooperative, usually in the ICUs we take an AP view where the rays comes from the anterior side and the plate is placed posteriorly. So here the heart is enlarged because heart is at a greater distance from the plate. So the heart seems to be enlarged. So what all X-rays I have given you, the most basic clinical thing is, look on the X-ray, it will be written as portable. If the X-ray is portable, it is mostly an AP view. Okay, so this is just a common sense. If you don't know any difference between an AP view and a PA view, on the X-ray, just look at the film. On the right upper hand, it will be written as a portable X-ray. So if it is portable, then it is an AP view. Then some other point of difference, the clavicles. The clavicles in a PA view will be over the lung fields. Can you see the clavicles in a PA view? It is over the lung field. And in an AP view, it will be above the lung apex. Can you see the difference between the position of the clavicles? Then the scapula. In an AP view, because the plate is placed anteriorly and the rays come from the back side, the scapulas will be away from the lung field. And in an PA view, in an AP view, it will be over the lung field. Then for the heart, as I told you, in an AP view, it will be relatively enlarged, and in PA view, it will be normal sized. Lateral view, just for your knowledge, lateral view, the position would be both the hands above the head, and it is usually useful for the lobar pathology, mediastinal masses, encysted pleural effusion, and basal consolidation. So if there is minimal pleural effusion, which is just seen as blunting of a CP angle in a AP or a PA view, it will be distinctly seen in a lateral view. Exposure. Adequate exposure, see, I have circulated one normal X-ray where you can barely see the intervertebral spaces through the heart shadow. Okay, in an overexposed lung field, it will be very radiolucent because the air is maximum. It will be very radiolucent. It will seem like an emphysematous chest X-ray. And in an underexposed, it will be very hazy. It will be all the bony structures will be very prominently seen. Then comes the rotation. So just you have to see that whether both the medial ends of the clavicle is at an equidistance from the midline or not. Okay. This is for the rotation. Patients with scoliosis, patients in ICU, mostly who cannot be positioned well, a rotated X-ray will be seen. See, this is a normal chest X-ray. Here we have an ABCD approach. First of all, we look for the lung fields. Is there any pathology in the lung field or not? So it starts with the trachea, then both the lung fields, then we go towards the bone. We can look for the rib fracture, we can look for any fracture of the clavicles, we can, then comes the soft tissue, that is the heart. Okay, see, airway, bones and soft tissue, cardiac shadow, then comes the diaphragm. Can you see the right and the left diaphragm? Then comes the CP angle and costophrenic and a costodiaphragmatic angle. Zones, okay, now the Silhouette sign. This is very important. This is usually asked in your table vivas. So the left border of the heart is made up of the arch of the aorta, then comes the main pulmonary trunk, then the auricle of the left atrium, and then the left ventricle. And the right border of the heart is made up of superior vena cava, the arch of azygous vein, right atrium and inferior vena cava. Remember, the right border of the heart is not made up with right ventricle. Right ventricle is beneath this structure, okay? Now CT ratio, that is the maximum transverse diameter of the heart divided by the maximum transverse diameter of the thoracic cavity, that gives you the cardiothoracic ratio. The normal ratio is less than 0.5. If there is any cardiomegaly, the ratio would be altered. It might be more than 0.5. So some cardiac X-rays, if CT ratio is more than 0.5, and in right ventricular enlargement, as the name suggests, the right ventricle is enlarged, okay? So if the right ventricle is enlarged, just you see, this is the heart. If the ventricle is enlarged, then the left ventricle would move upwards and outwards, okay? See, upwards and outwards. The cardiac apex will be round and elevated above the diaphragm. And in left ventricular enlargement, because the left border is made up with the left ventricle, if that is enlarged, then the heart will be pushed downwards and outwards. The cardiac apex is displaced downwards and to the left. Mitral stenosis, as the name suggests, there is enlargement of the left atrium. So it will be in line with the left ventricle. So there is straightening of the left heart border. There will be a double right heart border seen, and there will be a splaying of the carinal angle. So mitralization of the heart, there will be a small aortic knuckle, as you see. Then there will be enlarged pulmonary conus, a prominent left atrial appendage, and there will not be any change in the left ventricle. Then congestive heart failure. Can anyone tell me where is the X-ray of congestive heart failure from the X-rays that I have circulated? So in congestive heart failure, there will be increased interstitial markings, and bilateral effusion will also be seen, and there There will be a typical bat wing appearance. Can you see the bat wing appearance because of redistribution of the fluid in the upper zone? Cardiomegaly, a false cardiomegaly will be seen, and there might be minimal pleural effusions. What is this? Leather bottle appearance, which is usually seen in pericardial effusion. There is a globular heart shadow. What is this? And it is seen in? Okay, good. Then for the lung pathologies, a whiteout lung, that is mostly radio opacity. Radio opacities are seen in where there is fluid collection, where there is consolidation, collapse, fibrosis, coin lesions, miliary lesions, lung mass, hilar lymphadenopathy, pulmonary edema, and hemithorax. And black lung fields, that is where air is more in the cavity, that is pneumothorax, hydropneumothorax, caviting lesions, emphysema, and subcutaneous emphysema. Can you see the pleural effusion? There is an upwards convex concavity because there is effusion, that is fluid collection in the pleura. Over there also. Can you see here distinctly an upward concave wave? Then consolidation. Here there won't be any bronchovascular markings in the area where there is consolidation, but the difference between effusion and consolidation, see, there is an upward marking over here. That because the meniscal sign might be, Sangeeta ma'am might have told you. Okay. This is consolidation. This is collapse. There will be a tracheal shift in collapse, the region where there is a collapse. Here in the right upper zone, there is a shift of trachea towards the right side. Then comes fibrosis. Then miliary lesions. Can you see small white lesions in both the lung fields over here? See, this is fibrosis. And here there is millet-shaped round opacity seen in the entire lung fields. So, miliary lesions can be seen in miliary tuberculosis, sarcoidosis, pulmonary eosinophilia, histoplasmosis, pneumoconiosis, hemosiderosis, and as well as multiple miliary metastasis seen in thyroid, renal, breast, prostate, and osteocarcinoma. Can you tell me where the pneumothorax is in the right-sided X-ray? Can you tell me the lobe that has been involved? Where is the pneumothorax? Can you see any abnormality? Both the picture has pneumothorax, but where is it? Right lower lobe. Here. Can you see a triangular structure? Over here. The right lower lobe. And in the left side also there is this. Left sided. There won't be any bronchovascular markings in that area. You can see upwards all the lung fields has BVM. And in the lower side there is no BVM. Okay, and it will be more radiolucid. Then hydropneumothorax, that is air plus fluid, both air fluid level. These are the classical X-rays that are kept. Okay, see, we have a straight line, and then there down there is a fluid collection, and upwards there is air. So there is a straight demarcating line. Can you tell me what is that round thing in that X-ray? It is an artifact, right? Due to jewelry. Then pulmonary cavity. Can you show me cavity in this X-ray? Where is the cavity? Which side? Left, right? Left side. Okay, very distinctly a cavity is seen. So the cavities could be due to infection. It could be lung abscess due to multiple bacterial, fungal or amoebic infections. Then it could be due to cancer, it could be autoimmune, it could be vascular, it could be trauma. Then here, what is the abnormality in this X-ray? Can you show? Gons complex, anything? Both the upper lobes are involved. So in active tuberculosis, usually infiltrates are seen, consolidations or cavities as well as hilar lymphadenopathies are there. And in healed tuberculosis, we have pulmonary nodules, fibrotic scares and bronchiectasis. What is this? And is it normal? Okay. Anything else in this X-ray? Right side, the dome of the diaphragm is also elevated, right? And there is an air under the diaphragm. Air under the diaphragm is an acute emergency. Then this. Can you see multiple air fluid level? Even in the chest X-rays, you can see if there is a cut of the abdomen is taken. Okay. So this is also all surgical emergencies. I guess in the crash course of surgery, it might be covered. What is this? Excessive gaseous abdomen. Have you seen all those X-rays? Can anyone just tell me what were the abnormal X-rays in the 3 X-rays that I had circulated? Anyone of you who have seen the X-rays? See, just in the X-ray for the table vivas, you need to identify where the lesion is. You first of all pick up the X-ray and start speaking like this is a X-ray, this is a chest X-ray, PA view or an AP view. With underexposure or overexposure, rotation is there or not, and then start describing the lung fields and then the bones and then all the ABCDs that I have told you. Okay, and then go, do not just jump that this is cavity or this is a hemothorax. First of all, describe the X-ray. If a examiner tells you, just tell me the diagnosis by seeing this X-ray, only then go with that. Okay. ECG. I have an ECG also for you. Okay. ECG is defined as recording of the electrical activity of heart on a graph paper, and a machine that is used to record this electrical activity is known as an electrocardiograph. Significance of ECG, not important much. ECG paper. ECG paper, if some examiner might ask you that how does an electrical activity gets recorded on a paper? Is there any ink in the instrument or what is it? Anyone? So the ECG paper is a thermosensitive paper. There is no ink. The stylus which is present in the electrocardiogram due to vibrations. Okay, due to vibrations we get the waveforms based on the electrical activity of the heart. So there is no ink in the machine and it is just a thermosensor. Due to vibration, the paper gets the markings. So 1 square is 1 mm wide and 1 mm high. On this ECG, if you can see, there are thick lines, and in between those thick lines we have 25 small squares. Okay, see, between those thick lines there are 25 more small squares. Okay, and the ECG paper runs at a speed of 25 mm per second. This is the standard speed, 25 mm per second. So each small square would be 1 by 25 seconds, that is 0.04 seconds. So for that 3 seconds would be, see, and there is a marking at every 1 second interval. If you can see, after every 5 large boxes there is a marking. Okay, this will be very useful in calculating the heart rate. That is why this is important. Can you see a standardized marking after every 5 large squares? Okay. See, each small square on the y-axis is it is the seconds, which is 0.04 seconds, and the height is, the total height is 0.5 millivolts. So one small square, the height would be 0.1 millivolt. See. Okay, ECG leads. This is a very practical thing. It might not be asked in your table viva, but a 12 lead standard ECG has 3 bipolar limb leads, 3 augmented limb leads, and 6 chest leads. Positioning of chest leads might be asked. So here this is. V1 is usually placed in the 4th intercostal space, just right to the sternal border. V2 is a 4th intercostal space to the left sternal border. V3 is in between V2 and V4, and V4 is in the 5th intercostal space in the mid-clavicular line. Okay, so V3 is placed in between V2 and V4. V5 is in the anterior axillary line, and V6 is in the mid-axillary line. Then bipolar limb leads is, the red one is the right upper arm, so RBGY, that is the mnemonic. Right upper limb has red electrode, then comes the right lower limb, then we move in an anti-clockwise direction, then the green one is the left lower limb, and then the left upper limb. See, precordial limb leads. This is which triangle? Ethovens triangle. Okay, now always remember, positive electrode is always a reference electrode. Depolarization wave moves towards the positive electrode and gives a positive deflection. Depolarization wave that moves away from the positive electrode gives a negative deflection. Waveforms. P wave is made up of arterial depolarization, QRS complex is ventricular depolarization, which masks the arterial repolarization, and T wave is ventricular repolarization. Basic terminologies, if you have seen the ECG, there is a baseline which is a flat, straight and an isoelectric line. Waveform is deviation or movement away from the baseline, maybe upwards or downwards. Segment is a line between two waves is called a segment. Interval is a wave plus a segment is called an interval. And a complex is a combination of several waveforms without a segment. P wave. P wave shows arterial depolarization and its duration is, I'll speak in small square boxes only because that is important to check for the abnormalities. So its duration is 0.1 second, that is 2.5 small squares, and its height is about 2.5 small squares. Presence of P wave and an ECG strip shows a sinus rhythm. An abnormality. So P pulmonale, that is a tall peaked P wave, and a tall peaked P wave, it is usually seen in right atrial hypertrophy, so it would be covering more than 2.5 small squares. Then P mitral, it is a biphasic and a broad P wave. An M-shaped P wave might be seen, so it will be broad, so covering more than 2.5 small squares. And P waves are best seen in lead 2. QRS complex. QRS complex represents a ventricular depolarization and its normal duration is the complex, the entire complex. It is less than 2.5 or 2 small squares, and its height is about 5 to 20 small squares, that is 5 large squares. It is wide complex because it masks the arterial repolarization. Q wave is the first wave of this complex, but it is often absent, so it does not always mean that the patient had infarction. Okay, Q wave might be absent. There is a significance where Q wave presents the interventricular septal depolarization. It is the first negative ECG deflection on the ECG. Q wave, if it is greater than 1/3 the height of the R wave, then it will represent an old infarction. If just Q wave is there or if it is not seen, it is not an abnormality. Q wave greater than 1/3 of the height of R wave represents old infarction. Low voltage, this is all theory. Now high voltage QRS complex, this is important. If high voltage QRS complex is seen in lead V1 and V2, then it will suggest right ventricular hypertrophy, that is 35. If QRS, if it is both is more than 35 small squares, that is 7 large boxes, then it will suggest right ventricular hypertrophy. And if similarly such waves are seen in V5, V6, then it is left ventricular hypertrophy. T wave, it represents ventricular repolarization. It is a repolarization wave but shows an upward deflection because the part depolarized is in the last is forced to be repolarized. That is, the base of the heart depolarized is the last, but it is the first one to get depolarized. That is why we have an upward deflection. Okay. Now PR interval, this is important because sometimes ECG of AV block might be kept. It is the beginning of a P wave to the beginning of the Q wave. Its normal duration is 0.12 to 0.2 seconds and it represents the conduction time of impulse from SA node to the ventricles and AV delay. So, see, this is PR interval. Can you see over here? Starting of the P wave to the starting of the QRS complex. Usually it should be less than 1 small square, but if it is more than 1 small square, then we might say that this is a first degree AV block. The atrioventricular conduction is lengthened. And in a second degree AV block, there might be just a drop of QRS complex. Okay, a sudden drop of QRS complex, and here the PR interval is more than 0.4 seconds. QT interval, it is measured by the beginning of the Q wave to the end of the beginning of the Q wave to the end of the T wave. Its duration is about 10 small squares and it indicates the total systolic time of the ventricles. See, P wave, PR interval, that is beginning of the P wave to the beginning of the Q wave, QRS complex. Then QT is beginning of the Q to the end of the T wave, and RR interval is between the two QRS complex. We have a RR interval. ST segment, elevation and depression. See, now J point. This is very important again. The exact point at which all the ventricles are depolarized, that is at just the end of the QRS complex and the beginning of the ST. See, this is a downsloping ST, this is an upsloping ST, and this is a horizontal ST. So, J point is the end of the QRS complex and beginning of the T. The exact point, that is the J point. Okay. See, can you see the J point? End of QRS complex and beginning of the T. This is normal. But if the J point is upward or downward, concave or convex, it depends. In ST elevation MI, it is always convex. If there is an acute STEMI and if there is concavity, it might be an old infarction. This is ST depression. In ST elevation, there will be a convexity, and in ST depression, there is a concavity. See, this is a classical ECG that is usually kept here 2, 3 and AVF. The J point is elevated and there is an upward concavity which represents ischemia, and in V1 you can see elevations, tall elevations. Now here, where is the ST elevation seen? See V1, can you see V1, V2, V3? There are tall T waves and elevated J point. See, remember these ECGs, these are frequently kept. Any doubt in these ECGs? Calculation of heart rate. If there is a sinus rhythm, we have a very easy formula to calculate, that is the rule of 300. And here you just have to calculate the number of big boxes between the two neighboring QRS complex and then divide those number by 300, like 300 divided by the number of boxes between the two QRS complex. Can anyone, I have given you the ECG. Can anyone tell me the heart rate in that ECG? See, if there is a sinus rhythm, if there is a presence of P wave and sinus rhythm, this is the basic formula. Okay, another formula is a rule of, okay, tell me heart rate in this ECG first. (300 divided by 5), 60, okay, but this is only for a normal sinus rhythm. Here, will you be able to calculate with this formula? No. Okay. So, for that we have a 10-second rule or maybe a 6-second rule. I'll make it easy. See, each small square was 0.04 seconds. So, a big square would be 0.2 seconds. So, 5 such squares would be 1 second. Okay. So, we'll take, for 6 seconds will be 5 into 6. That will be 30 boxes. Okay. 30 big squares. That will be 6 seconds multiplied by 100. Calculate the number of QRS complex in those 30 large boxes. 30 large boxes. Remember 30. 30 large boxes is equal to 6 seconds and multiply it by 10. Okay, so that will be in a minute. So, number of QRS complexes in 30 large boxes into 10, that will give you the number of heart rate. These are the just two more important things is calculation of the heart rate and identification of the rhythm. Rate and rhythm, that is the only thing that has been asked in the ECG for a practical purpose, otherwise everything is theory. Then comes the management, the presentation and the management. Okay. Now going on to the rhythm. This is checked by the interval between two R waves or two S waves. If the number of small or large squares are equal between two R or S waves, the rhythm is said to be normal. If it is not the rhythm, if it is not regular, then it is irregular. Okay, sinus arrhythmia. If there is PQRS complex is present, but the RR interval is different, which normally does vary with inspiration and expiration. So that is known as sinus arrhythmia. Heart rate usually increases during inspiration and decreases during expiration. Now comes the atrial flutter. When the arterial rate is in between 200 to 300 beats per minute, and the AV node is not able to transmit from SA node the impulse goes to AV node, and from the AV node through the Purkinje fibers it goes to the ventricles. But when the AV node is not able to transmit all the impulses to the ventricles, so the ventricular rate is 1/3 or 1/4 of the atrial rate. Here P wave is like sawtooth. See, impulses travel in a regular and circular course in the atria and it does not get transmitted to the ventricles. So there is no interval between T and P. Here all the QRS complexes are on its own. So saw-shaped T and P waves are atrial flutter. Atrial fibrillation is a totally irregular and rapid atrial rate in which there is contraction of only a small portion of atrial musculature. P waves are replaced by irregular fibrillatory waves because the whole atria is not contracting. QRS complex and T waves are normal, but rhythm is irregular. In atrial flutter, the rhythm would be regular, but saw-shaped P and T waves with regular rhythm. Irregular rhythm with fibrillatory waves. Now, here we have both flutter as well as fibrillation in the same ECG. And you are usually asked to identify the abnormality in this ECG and calculate heart rate. Okay, here the P waves are absent. There is a narrow complex tachycardia and irregular RR interval. Then comes ventricular tachycardia. Always remember, do not tell this as ventricular fibrillation because fibrillation is almost never captured on an ECG. Ventricular tachycardia, it is a wide QRS complex tachycardia giving a spindle-like appearance. Even more than 3 consecutive premature ventricular beats at 100 per minute. Northwest axis is there. with positive QRS complex in AVR. Usually AVR is a negative deflection. Fusion and capture beats might be present. If any time you see such an ECG, it is ventricular tachycardia, or do not jump to the word ventricular tachycardia. Just say wide complex tachycardia. Okay, then management of VTVF. So, in short, for X-rays, identification of X-rays is important, and for ECGs, heart rate and identification of the pathology. Only 6 ECGs are usually kept, that is AF, AFib, atrial flutter, VT, and STEMI, and a normal ECG, nothing else. Okay, thank you. Moving on towards pharmacology, like instruments and medicines, it will be taken by Dr. Ibrahim.
દસ થી 15 મિનિટ થશે. ઇન્સ્ટ્રુમેન્ટમાં લોચા મારો છો તમે લોકો. લેરેન્જિયોસ્કોપ જ્યારે આપીએ ત્યારે તમારાથી થતો નથી, એટલે જેટલા જાય છે એટલું લાગે છે કે આવડતું હશે. I will start with instrument. First is ambu bag. અંબુ બેગ સૌથી પહેલા અમે લોકો નામ પૂછતા હોય છે, અંબુ બેગનું પૂરું નામ બોલો, તો યાદ રાખી લેજો. આર્ટિફિશિયલ મેન્યુઅલ બ્રીથિંગ યુનિટ ઇઝ હેલ્ડ ફોર એ ઇમરજન્સી કન્ડિશન. બરાબર. ધ ડિવાઇસ કન્સિસ્ટ ઓફ એ સેલ્ફ ઇનિશિએટિંગ ઇન્ફ્લેટિંગ બેગ with a one-way valve and a face mask or an adapter for an advanced airways like endotracheal tubes. When the bag is compressed, it forces air or oxygen into lung. It is essentially during cardiac arrest or a respiratory failure where mechanical ventilation is not immediately available. Okay. આમાં મેન તમને અંબુ બેગમાં કેટલા CPR પર કેટલી વખત અંબુ 30:1 રેશિયો. બરાબર, એ યાદ રાખજો. સેકન્ડ ઇઝ લેરેન્જિયોસ્કોપ. બે બાજુ બ્લેડ છે, વન ઇઝ મેકેન્ટોસ એન્ડ સેકન્ડ ઇઝ મિલર. આપણા ત્યાં મોસ્ટલી મેકેન્ટોસ બ્લેડ જ હોય છે, જે કવ હોય. મિલર બ્લેડ્સ આપણે મોસ્ટલી યુઝ નથી કરતા, પણ અમુક હોસ્પિટલ્સમાં છે જે રાખી છે. બરાબર. લેરેન્જિયોસ્કોપ ઇઝ કોમનલી યુઝ ડ્યુરિંગ એન્ડોટ્રેકિયલ ઇન્ટ્યુબેશન ટુ વિઝ્યુઅલાઇઝ લેરિંગ્સ, particularly the vocal cords and the glottis. This allows the clinician to pass a tube safely into trachea rather than a esophagus. This is endotracheal tube. We are commonly using કે લેરેન્જિયોસ્કોપ જોડે બીજું શું વાપરવાનું, તો આ તમારે લોકોને ખબર હોવી જોઈએ. બરાબર. સિરિંજ ઇન્ફ્યુઝન પંપ બહુ ઇઝીલી પૂછતા નથી, બહુ સારું આવડ્યું હોય તો જાય આના ઉપર વાયવા. બરાબર. ઓક્સિજન ડિલિવરી માસ્ક કોમનલી યુઝડ. ઓક્સિજન ડિલિવરી માસ્કમાં 3 ટાઈપના માસ્ક, કોમન નેઝલ કેન્યુલા, સેકન્ડ ઇઝ સિમ્પલ ફેસ માસ્ક એન્ડ NRBM માસ્ક એન્ડ વેન્ચુરી માસ્ક. નેઝલ કેન્યુલાથી 24 to 44% FiO2 જેટલું ઓક્સિજન જાય. સિમ્પલ ફેસ માસ્ક 35 to 50%, NRBM થી 90% FiO2 and Venturi mask is 24 to 60%, and Venturi mask commonly used for COPD patients. Okay. Oropharyngeal airways. These are the airways which we use as a oropharyngeal, also known as a Goodell's airway. It is a rigid plastic device used to maintain open airway by preventing the tongue from covering the epiglottis. Commonly used during intubation. Peripheral IV cannulas. કોઈને આની સ્લાઇડ્સ જોઈતી હોય તો હું આપી દઈશ, ફોટા ના પાડો, જોઈ લો ને ઓલરેડી ઓનલાઈન છે જ આ. બરાબર. સ્લાઇડ જોઈતી હશે તો હું આપી દઈશ. બરાબર. બહુ પેરિફેરલ આઈવી કેન્યુલાસ 14 ગોસથી 24 ગોસ સુધી આપણે વાપરીએ છીએ. નંબર્સના હિસાબે ઓરેન્જ, ગ્રે, પિંક, બ્લુ એન્ડ યલો આ કલર છે. આર્યનને આપી દઈશ, આર્યન પાસે સ્લાઇડ લઈ લેજો. બરાબર. સેન્ટ્રલ વેનસ કેથેટર કહી દઈશ છેલ્લે જતા જતા આર્યન છે આના પછીથી લઈ લેજો. Central venous catheter is a long thin tube placed into a large vein such as internal jugular, subclavian or a femoral vein, commonly used when peripheral veins are not possible or in a critical condition where we have to assess the large vein and give multiple antibiotics or vasopressors. Okay. Sphygmomanometer આવડતું હશે ને? થર્મોમીટર ફાવશે ને? પલ્સ ઓક્સ બરાબર. હવે આ હેમર ને આ બધા અમે કોમનલી મૂકતા હોઈએ છીએ, પણ તમને આરટી કેથેટર, લેરેન્જોસ્કોપ, ઈટી, ઓક્સિજન માસ્ક ને પેરિફેરલ આઈવી કેન્યુલાસ આના ઉપર જ મોસ્ટલી તમારું જે 10 કે 5 મિનિટ હોય છે પતી જતી હોય છે. બરાબર, એટલે તમને આરટી કેથેટર પર સીધો લઈ જાઉં છું. નેબ્યુલાઇઝર ડિલિવરી, Ryle's tube, RT. Nasogastric tube or Ryle's tube is a flexible tube passed through a nose, past the pharynx and into stomach. It is used for two main purposes: decompression and enteral feeding. Gastric fluid for which pH testing or by chest and abdominal X-ray. Injecting air, જ્યારે આનો વિડીયોઝ ઓનલાઈન હશે જોઈ લેજો કે કઈ રીતે પાસ કરીએ છીએ અને કઈ રીતે ઇન છે કે નહીં અમે આપણે કન્ફર્મ કરીએ છીએ. આ જ વસ્તુ પૂછશું ત્યાં, એ પૂછાય છે. બરાબર. Follis catheter, a urinary catheter, specifically the Follis catheter is a flexible tube inserted to the urethra into the bladder to drain urine. It is an indwelling catheter held in place by an inflatable balloon, typically a two-way or a three-way. Continuous bladder irrigation, commonly used after prostate surgery. Indications include urinary retention, output measurement. Catheter associated UTI is a common complication. Laryngopharyngeal mask, આ નહીં પૂછાય બહુ. Tracheostomy tube, this is common. બરાબર. Tracheostomy tube ક્યારે યુઝ કરવાની? જ્યારે એન્ડોટ્રેકિયલ ઇન્ટ્યુબેશન તમારાથી પોસિબલ ના હોય ચેટે ટાઈમે. બરાબર. ટ્રેકિયોસ્ટોમી ટ્યુબ બીજા કયા પેશન્ટમાં યુઝ કરવાની કોમનલી? સૌથી પહેલો ક્વેશ્ચન ત્યાં આવીને ઊભો રહેશે. રેબિસ અથવા ટીટેનસ વાળું પેશન્ટ, સોરી ટીટેનસ વાળું પેશન્ટ હોય એમાં સૌથી પહેલા યુઝ કરવાની. બરાબર. IV solution bottles, normal saline, ringer lactate, DNS. Normal saline isotonic used for a fluid replacement and flushing. Ringer lactate isotonic used for trauma and electrolyte replacement. Dextrose provides calories and free water, and DNS hypertonic provide both energy and volume. લેબોરેટરી કલેક્શન, આ ફોટો પાડી લેજો. આમાં બહુ લોચા પડે છે તમારે. પર્પલ EDTA used for complete blood count, HbA1c. Red biochemistry, electrolyte, liver function test. Light blue sodium citrate, commonly used for coagulation profile. Green, which is heparin. Plasma determination, stat chemistry. Gray, which is fluoride, blood glucose or lactate. Yellow, DNA studies and tissue typing. Metadose inhaler, which is we are commonly used in a COPD or asthma patient, commonly used with a spacer. Metadose inhaler ત્યાં પડ્યા હશે, સ્પેસરમાં પડ્યું હશે. એક્ઝામિનર રીતે પૂછશે કે સ્પેસરમાં કઈ રીતે યુઝ કરવાનું, તો એક વિડીયો ખાલી જોઈ લેજો, ઓનલાઈન મળી જશે. મીટાડોઝ ઇન્હેલર પુશ કરીને સ્પેસરનું આગળનું ઢાંકણું બંધ કરવાનું, પછી પફ કરીને જ આગળનું ઢાંકણું ખોલવાનું કહેવાનું. ઓકે. ઇન્સ્ટ્રુમેન્ટ પતી ગયા છે. ડ્રગ હું ખાલી ડિક્ટેટ કરી દઈશ. બરાબર. ઉતાવળ નથી ને? ખાસ ઇમરજન્સી શીખવવાની છે. બરાબર. 5 કે 6 જ ઇમરજન્સી છે. હું કોમન ડ્રગ્સ આપણે જે મૂકીએ છીએ ટેબલમાં ડિક્ટેટ કરી દઉં છું. ક્યાં ગયા પેલા? બોલાવજો ને અને કરજો સ્ક્રીનમાં. બધી સ્લાઇડ્સ આપી દઈશો ત્રણે તો. એડ્રેનાલિન કોમનલી યુઝ, બરાબર. ક્લિનિકલ ઇન્ડિકેશનમાં એનાફાઇલેક્ટિક શોક, કાર્ડિયાક અરેસ્ટ, સિવિયર બ્રોન્કોસ્પાઝમ. ક્લિનિકલ એનાફાઇલેક્ટિક શોકમાં ડ્રગ ઓફ ધ ચોઇસ એડમિનિસ્ટર IM 0.5 to 1/1000. ઓકે. Complications tachycardia, severe hypertension, palpation, tremor, anxiety and ventricular arrhythmias. MPS or a dexamethasone. Steroid MPS used as a pulse therapy in SLE, dexamethasone, cerebral edema, meningitis, adrenal insufficiencies. Commonly side effects are hyperglycemia, heterogenic Cushing's, osteoporosis, peptic ulceration, psychosis. Theophylline, commonly used in COPD asthma patients. Atropine, OP poisoning commonly used. Atropine is a drug of choice in OP. Symptomatic bradycardia, first line ACLS treatment, pre-anesthetic to reduce the salivary and bronchial secretions. Insulin commonly used in diabetes, hyperkalemia with dextrose to shift potassium intracellularly. Digoxin we will use in atrial fibrillation or heart failure with reduced ejection fraction. Commonly side effects are nausea, vomiting, heart blocks and bigeminurity. Antihypertensive, these are the commonly used antihypertensive that we are using as ACE, ARB inhibitors, CCBs or diuretics. Beta blockers are also used, which we will mention later. Atorvastatin, dyslipidemia, ischemic stroke, myocardial infarctions. Aspirin, same as above. Clopidogrel, આ તમને જ્યારે ઇમરજન્સીઝમાં સ્ટેમી આવે છે, જે તે ટાઈમે તમને પૂછશે જ મેનેજમેન્ટ શું આવશે, એ ટાઈમે તમને ડોઝ જોડે યાદ હોવું જોઈએ. સ્ટેટિન 80, એસ્પિરિન 3, એસ્પિરિન, ક્લોપિડોગ્રેલ. એ ક્લોપિડોગ્રેલ કેટલી હતી? આ કોમનલી યુઝડ આપણે ત્યારે સવાલ પૂછતા જ હોઈએ છે, વાંધો નહીં પછી. લેવેટ્રાસિટામ, કોમનલી યુઝ એઝ એન્ટી એપિલેપ્ટિક, ફોકલ સીઝર્સ ને જનરલાઇઝ ટોનિક ક્લોનિકમાં. અત્યારે એક નવી આવી છે બેવેટ્રાસિટામ, બરાબર. લેવેટ્રાસિટામ ને બેવેટ્રાસિટામનો એક વખત જોઈ લેજો. ફોકલમાં બેવેટ્રાસિટામ યુઝ નથી કરતા, બરાબર. સોડિયમ વાલ્પોરેટ, અનધર એન્ટી એપિલેપ્ટિક. કાર્બામેઝાપાઇન, એન્ટી એપિલેપ્ટિક. આ એક જ એન્ટી એપિલેપ્ટિક છે જે સ્ટીવન જોન્સન સિન્ડ્રોમ કરે છે, એટલે જે તે ટાઈમે યાદ રાખજો. લીવોડોપા પ્લસ કાર્બિડોપા, પાર્કિન્સન ડિસીઝ, કોમન સાઇડ ઇફેક્ટ nausea, vomiting, orthostatic hypotension. Oral hypoglycemic agents like metformin, SGLT2 like dapagliflozin, DPP4, sulfonylureas. Thyroxine, iron, folic acid, commonly used in iron deficiency anemia or pregnancy or during lactations. ART, TLE regimens and HRZE. આ પ્રોગ્રામ વાંચ્યા છે બધા? ખાલી વાંચી લેજો. HRZE, rifampicin, orange commonly adverse reaction, orange color urine, hyperotoxicity, isoniazide, peripheral neuropathy, ethambutol optic neuritis, pyrazinamide, hyperuricemia, and most hyperotoxic pyrazinamide is. Anti-malarial drug. Anti-malarial drugs, falciparum aceticate, which contains artesunate and lumefantrine. Vivex, chloroquine is followed by primaquine. Chloroquine causes pruritus, retinal toxicity, primaquine hemolysis in a G6PD deficiency patient. So we always measure G6PD prior to giving a primaquine. Antifungal drugs, fluconazole. Amphotericin B causes nephrotoxicity, hypokalemia, infusion reaction, and fluconazole is an enzyme inhibitor. Beta blockers, which I have mentioned earlier, commonly used in heart failure with reduced ejection fraction, hypertension, thyrotoxicosis. આમાં કાર્ડિયો સિલેક્ટિવ છે, એ વાંચી લેજો. વેરાપ્રામિલ, લિટિયાઝામ, commonly drug of choice in a supraventricular tachycardia, atrial fibrillation. cause side effect can cause bradycardia, AV block, constipation and gingival hyperplasia. Amiodarone, ventricular tachycardia, જે મેડમે ભણાવ્યું એમાં ventricular tachycardia, broad complex ventricular tachycardia હોય, amiodarone is a drug of the choice. Duolin, good record. હવે ઇમરજન્સી બસ 5 મિનિટ, પણ ઇમરજન્સી 5 છે, 5 મિનિટ તો નહીં, થોડી વધારે થશે. કાર્ડિયાક અરેસ્ટ. ડેફિનેશન, સાઇન્સ એન્ડ સિમ્ટમ્સ કયા જોડાઓ છે? અનરિસ્પોન્સિવનેસ, એપનિયા એન્ડ પલ્સલેસનેસ. ડાયગ્નોસિસ ઓન ઇસીજી, preliminary clinical ECG or a defibrillator used to identify shockable rhythm versus a non-shockable rhythm. Shockable rhythm is VF or pulseless VT. Broad complex tachycardia, ventricular tachycardia which is pulseless is always shockable. ACLS management, high quality CPR, 100 to 120 compression in 2 to 2.5 each depth, full chest recoil, minimize interruption, compression, ventilation ratio is 30:2. Defibrillation for VF or a VT, immediate shock 200 joule biphasic followed by 2 minute CPR. Check the rhythm or a pulse after each cycle. Pharmacology, adrenaline 1 milligram IV every 3 to 5 minutes and called amiodarone 300 milligram stat, 300 milligram then 150 milligram for a refractory VF after third shock. MI, signs and symptoms, pain associated symptom, diaphoresis, nausea, dyspnea, sense of impending doom, atypical, epigastric pain in elderly, females or diabetic. Diagnosis, ECG shows ST elevation and a T wave inversion is the gold standard. Primary clopidogrel 300 to 600 milligram loading dose. પ્રાઇમરી ટ્રીટમેન્ટ ઇઝ તમને છે ને ડાયરેક્ટ એવું જ પૂછવાશે કે મેનેજમેન્ટ શું, તો પ્રાઇમરી મેનેજમેન્ટ જો તમારા પાસે પીસીઆઈની કેટલેબ અવેલેબલ હોય, પ્રાઇમરી ઇઝ અ પીસીઆઈ. ઓકે, નથી અવેલેબલ તો થ્રોમ્બોલિસિસ, સ્ટેપ્ટોકાઇનેસ, યુરોકાઇનેસ. ઓકે. Status asthmaticus. Definition, severe or life threatening asthma attack is a refractory to initial standards of a bronchodilator therapy. Signs of severity, respiratory, auscultation and objective. Diagnosis can be done on clinical basis. Stepwise emergency care. Oxygenation is the main part in this management. SpO2 94 to 98% is target. Bronchodilator, salbutamol, hypertropium, nebulized every 20 minutes or and IV magnesium sulfate if refractory. Steroids, IV hydrocodone 100 to 200 milligram or oral prednisolone 40 to 50 milligram. IV is the best treatment. આપણા પાસે સ્ટેટસ અસ્થમેટિકસમાં આવ્યું છે તો IV જ આપવાની છે. એપિલેપ્ટિકસ. એપિલેપ્ટિકના પહેલા સૌથી પહેલા ડેફિનેશન પૂછે, સીઝર એક્ટિવિટી that last for more than 5 minutes or 2 or more seizures without regain of a consciousness in between. Signs and symptoms, convulsive, rhythmic, tonic-clonic movements, tongue biting, urinary incontinence. Diagnosis, clinical observation, check capillary blood glucose for hypoglycemia. Pharmacological therapy, 0 to 5 minutes માં stabilization, ABC, O2, IV assess, blood sugar check. 5 to 20 minutes માં initial therapy, lorazepam or midazolam. And 20 to 40 minutes માં levetiracetam or phenytoin. And more than 40 minutes માં ICU admission and anesthetic agent like propofol. બધામાં ડોઝ પૂછે તો 0.1 mg per kg આ બેઝિક બોલી આપવાનું. બધા આના ડોઝિસ આ રીતે જ છે સ્ટેટસ એપિલેપ્ટિકસના બધાના 0.1 mg per kg. ડીકે, metabolic triad, hyperglycemia, ketosis and metabolic acidosis. Diagnostic criteria માં urine ketones positive, acetone positive, blood glucose more than 250, ketone smell, ABGA pH less than acidosis is there. Management, fluid replacement, insulin therapy and electrolyte imbalances. Hypoglycemia, blood glucose less than 70 with symptoms of hypoglycemia that resolves after glucose administration. Correction, Rule 15. Give 15 gram simple carb, juice or sugar. Recheck glucose in 15 minutes. Repeat if still 70. Unconscious 25 dextrose, 100 ml or 50 dextrose, 50 ml bolus. Emergency non-IV. Glucagon 1 mg IM or a sub-Q if no IV access is there. Anaphylaxis. First line management 0.5 milligram adrenaline, IM 1 gem 1000 dilution, then fluid, auxiliary therapy H1 antagonist, chlorpheniramine, and then steroid hydrocot. OP treatment of choice palm and atropine. Palm 1 to 2 milligram 1 to 2 gram IV over 30 minutes, then infusion, effective if given early. Atropine 2 to 5 milligram IV bolus, double dose every 5 minutes until atropinization. Signs of atropinization commonly asked in OP poisoning. Okay. Snake bite. Anti-snake venom. We have to first check for 20 minutes WBCT, whole blood clotting time. 10 vials of anti-snake venom in 500 ml over 1 hour. Repeat 10 vials if no improvement. Total 13 vials can be given. Neostigma test for neurotoxic snake bite 0.5 to 2 milligram neostigma in IM plus atropine. Monitor for improvement in ptosis or a power. Wound tetanus toxoid, antibiotics for cellulitis. Thank you. કોને આપવાની છે સ્લાઇડ સ્લાઇડ આ લોકોને આપી દેજો ને મારા વાળી
એ ઓનલાઈન છે જ આપણે ગ્રુપ
ઓનલાઈન ગ્રુપમાં સ્લાઇડ આવી જાય છે ને આ લોકોને સ્લાઇડ આપી દો વોટ્સઅપમાં કોઈ એક જણ આપી દો અત્યારે અદિતભાઈ તમને આપી દેશે સ્લાઇડ બરાબર કોઈ એક જણ લઈ લો બીજાને સર્ક્યુલેટ કરી દેજો ટેબલમાં આટલું કરી લેશો થઈ તો જશો